Good afternoon, everyone. You are very welcome to the Winter Preparedness 2023-2024 Health and Social Care Preparedness Health and Social Care Workers Vaccinations webinar. The panel would be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. I will now hand you over to your host, Samia Paul, Health and Promotion Improvement Officer. Thank you.
Hi, good afternoon, everyone. My name is Soumya Paul. I'm a Health Promotion and Improvement Officer here in CHOD NCC. I'm delighted to welcome you all to the fourth webinar of our October Staff Health and Wellbeing Month series. This is run in conjunction with the Human Resources. Today, we have Dr. Paul Mullane with us. I'm delighted to welcome you, Dr. Paul, to our lunchtime webinar today. Dr. Paul is a specialist in public health medicine. He's going to talk about common myths about vaccinations and the importance of getting the flu and COVID-19 vaccine this winter for all the HSC employees. I'm sure this topic is of much relevance as many of you are involved in preparing and implementing the winter preparedness plan. And if you have any questions for Dr. Paul, please pop them into the Q&A feature and we'll try and get to them at the end. And if you're on social media and if you'd like to tweet this event, please do so and use the hashtag StaffHealthDNCC. We'll also have a survey at the end of the webinar, and by completing it, you will be entered into a draw to win a €25 one for all voucher. Without any further ado, I will now hand you over to Dr. Paul. Thank you.
Thank you, Soumya. Many thanks for that kind introduction, and delighted to be here today to present during Staff Health and Wellbeing Month. So I'm going to proceed with the presentation now. Thank you. Okay. So as Soumya mentioned, I'm going to present today on the topic of winter preparedness for this forthcoming winter season 2023-24, and also with a special focus then on vaccination for health and social care workers. And this is particularly pertinent around this time of year as it's the beginning traditionally of the influenza, the flu season. Apologies, just need to advance the slide here.
If you click your mouse anywhere on the screen, Paul.
Perfect. Thank you very much. So as Soumya mentioned, I'm a specialist in public health medicine working in HSC Dublin and North East. Just a brief touch on that as to what that means. So the new Sláinte Care regions or regional health areas that people may have heard of, Dublin North East encompasses the whole geography of CHOD NCC and also the HSC North East region. So I would have a remit over that entire geographic area. The focus today, of course, though, is on Dublin North. So public health, what do we do? What's the public health approach in terms of issues that might affect our populations? Well, it can be boiled down quite simply to the factors you see on screen here. So we can argue the pros and cons of things, but in every argument you need to bring data. So that's what surveillance is about characterizing what our issues might be, what the threats to health might be. And from that data, then we look for risk factors. So in this instance, respiratory viruses that occur in the autumn and winter season, and what might be the underlying causes and the patterns of transmission. We look for interventions that can hopefully contribute to the betterment of health and the prevention of ill health. I'm going to speak, of course, about COVID-19 and influenza vaccines this afternoon. So that's an intervention, and we know that these work in mitigating against infection and severe disease. But crucially, implementation. So what gets done is ultimately what matters, and how do we do it? And so just because there's an issue and we've characterized it and we have an intervention, ultimately we need to put it into practice. And I suppose that's what I'm here today to advocate for and to highlight why this is such an important topic, particularly at this time of year. Public health broadly can be described in what are called 4 domains or pillars of practice. So that's health protection, health improvement, health services, research and improvement, and health intelligence. What I'm discussing today falls into broadly the bracket on health protection, so guarding against infectious disease threats and optimizing the uptake of immunization programs. So winter preparedness, why should we prepare? I suppose the old adage is fail to prepare, prepare to fail. And, we don't want to fail or be found wanting when it comes to the care we provide for the populations that we are looking after, and also for our own colleagues within health and social care services. So as mentioned, this time of the year, respiratory infections, including the big hitters of COVID-19 and flu, they can co-circulate, so meaning that they're going around among people at the same time and potentially at high levels. And that can put those who are vulnerable in particular at increased risk, and it can put pressure on hospitals and other healthcare services in the community. It's also important to recognize that these aren't the only threats, and we often see other things such as gastrointestinal infections hit us in the winter, in particular norovirus or winter vomiting bug. And so infection prevention and control measures are crucial to prevent the spread of infection and feature heavily in winter preparedness and planning for winter seasons. When I refer to infection prevention control, I'm going back, you'll see the icon on the left of the screen from, I suppose, during the pandemic in relation to hand hygiene. And again, it's not necessarily groundbreaking or rocket science, but it's back to good old-fashioned first principles that good hand hygiene, good respiratory etiquette, so that's smothering coughs and sneezes with the tissue or into the elbow, along with then using PPE, things like face masks or otherwise, when necessary or when advisable, can all go to prevent unnecessary infection and ill health. In terms of health and social care services, I guess effective prompt recognition and management when cases of infection do occur, either among the patients or clients or residents we care for, or indeed among ourselves as health and social care workers. Prompt recognition of that, the prompt management of outbreaks, they reduce the spread of infection within care environments. And we want a safer care environment overall, not just for the people we serve, but also for us as health and social care workers to ensure that resilience. In terms of preparedness plan, I guess the key points I would highlight are that these need to be physical things, or at least digital versions, if not in hard copy, but they are in writing and they're accessible to staff, and that senior clinical management in health and social care organizations review and evaluate them at least annually ahead of each season, and revise if there's any changes to guidelines or otherwise. I've included a couple of links to examples of winter preparedness plan templates in sequence here. These are from the Irish setting, from the Australian setting, and from the UK setting. And these are useful for clinical managers in facilities to refer to ensure that, well, what should go into a winter preparedness plan. And indeed, that's what I'm going to just touch on briefly now. And this is not an exhaustive list necessarily of what should be in a plan, but it certainly highlights key points that need to be considered. Ideally, in a health and social care organization or facility, it's ideal if you have a lead or maybe a number of leads or champions around the management of COVID-19 and influenza, or an infection prevention control link practitioner or champion. It's key as well in winter preparedness plans to have up-to-date listings of your staff, your patients or residents, contact numbers and so on of next of kin or advocates or otherwise, information on vaccination and vaccination stock and ordering, PPE stock and ordering, communications materials around common seasonal illnesses and what to do if unwell, how to seek help and so on. And also as well, it's usually prudent to have a set of SOPs, standard operating procedures, about what to do locally when you have a case of a particular illness in a resident, patient, or a staff member, be that flu, COVID, respiratory syncytial virus, that's RSV, or other viral respiratory infections. And also what to do if indeed there's a clustering of cases and it becomes an outbreak. I'll focus here, obviously this is about staff health and well-being this month, and I'm obviously presenting to health and social care staff. We saw a lot of this, of course, at the height of pandemic waves, and perhaps when there was a lot more maybe uncertainty and even perhaps a fear of, the unknown of what was going to come and what protection would be afforded by vaccine and other measures taken. And we've always have said, if you have any even mild symptoms, we don't want people coming into a healthcare environment, and that still stands. It isn't just a pandemic related measure. So it can be a bit more difficult maybe in people's minds now when, say, the emergency is stood down to think that that's maybe feasible. But COVID hasn't gone away. The other respiratory viruses that maybe were kept at bay by lockdowns and so on have made their return. And it's important that if you as a health and social care member are not 100%, you're not well, and you're displaying symptoms that could be of a respiratory viral infection or indeed a gastrointestinal infection, that you shouldn't come into a healthcare environment. Now, I spoke about resilience, and obviously within winter preparedness plans, then it's important that organizations think, well, do we have the adequate staff levels and skill mix to absorb that if somebody is struck down with respiratory viral illness and they have to be off the factory floor, so to speak, because some people might have a particular set of skills or expertise that's not maybe readily replaceable. So part of winter preparedness planning is seeing, do we need to upskill other members such that if a number of people get ill at one time and we want to keep them out of the healthcare environment until they've recovered, that we are able to deliver our services as we wish to. So this is about our contingency planning. In terms of if indeed cases occur or outbreaks occur in the settings in which you work or in which you manage clinically, it's important as well to review after the fact what went well, what could have been done better, and what might be incorporated into a future winter preparedness plan or standard operating procedure. But key to all of this then is staff well-being, and that's the theme of this month and the theme around this talk, in that all of the above is kind of for naught unless the people in charge and the clinical management of teams gives people a sense of value, that they're part of a team, that there's flexibility, that there's the chance to be educated and upskilled, and that staff well-being is crucial, because if staff aren't well, they can't do their job well, and then the resilience in the service and the quality that we can provide for patients and residents and clients, it's more difficult then to maintain, especially in the pressures of winter. I'm just going to talk briefly about some work that was done internally in the Department of Public Health here, and mainly led by our health protection nursing colleagues. This focuses on the residential care or nursing home long-term care facility sector for older persons, but it has lessons that are applicable across the piece for mental health, disability, and otherwise. This was in relation to surveying persons in charge, mainly directors of nursing, their assistants, and also healthcare assistants and nursing staff working on the floor, so to speak, in residential care settings. Just a bit of background before I give some of the maybe key findings that we noted from this, is that it goes without saying that respiratory viruses, they're responsible for considerable morbidity and even potential death in nursing homes. I don't have the figures broken down here specifically to focus on North Dublin alone, but for the Dublin Northeast region during the flu season last year, that would be from the beginning of October to the end of April, there were nearly 140 respiratory viral outbreaks in this sector alone, the majority COVID-19, but nonetheless there were still influenza and other pathogens. And ultimately, you need a combination of interventions to minimize the impact of the respiratory viral season on, in this case, residential care, but also across other healthcare services. I've touched on winter preparedness and planning, and having that plan reviewed and updated and instigated. There's also important that staff are brought along and educated on and trained, and are able to even come to an event like this and discuss key points that they wish to learn more about. And one point I put here in bold, of course, is that vaccination is one of the key things we have in our armory to protect patients, protect ourselves, protect our families. So maximizing COVID and flu uptake seasonally, vaccine uptake seasonally is crucial. This survey that I've mentioned involved, as I say, focusing on both clinical leaders in residential care and also staff on the factory floor, and getting an idea about preparedness and education and also vaccine uptake. So I'll present just some of the headline features of this and some of the recommendations. I guess it was heartening to see that a majority, both from people who were, say, directors of nursing and also people working on the floor at ward or unit level, that a majority stated that their facilities indeed had winter preparedness plans in place. Not that it was 100%, but a vast majority. And that means we're on a good footing at the beginning, and that it's not that we are way behind. I'd mentioned about vaccination, and obviously that's some of the core aim of this talk, but this slide is maybe seems slightly out of place, but I still want to, I suppose, hammer the point home that the WHO, the World Health Organization, it cites two key interventions for public and population health that are probably, the top of the pile. One is clean water, which we can tend to take for granted in the Western world, and the other being vaccination. So ultimately, vaccination, it's the best protection we have, in addition to our other measures around infection control for unpredictable viruses. Flu has been around, seasonal flu has been around with us for a long time, but it can still be unpredictable, and we can have either mild or more severe seasons. So it's important to keep that in mind throughout this discussion. You don't need to internalize all the detail on this slide, but what this looks at is, when we surveyed these sectors, it was asked, who's in charge of promoting the seasonal vaccines where you work? And perhaps unsurprisingly, of course, many respondents indicated that it was their director of nursing or assistant, their person in charge, or maybe the linked general practitioner for the facility. But what that says to us is that, senior clinical managers are seen as a source of direction, a source of information, and they can be key advocates in ensuring all of the above around winter preparedness plans, vaccination uptake, not just for staff, but indeed also for the residents or patients under their care. In terms of educational sessions, again, it was, I guess, heartening overall to see a majority of their respondents to our survey showed that all staff were attending educational sessions last season on both flu and COVID-19. That said, there's still a bit more to do in that about a third of the respondents, give or take, would have said that maybe not all staff would have attended education sessions, but there may have been other reasons for that, because it may be to do with shift work or availability, or indeed, ironically, illness in people that kept them away from the workplace at that time. In terms of uptake, the key points to kind of internalize here, it's the point in bold, is that the flu uptake last season among staff in residential care facilities in the North Dublin region was just around half, just under half at 48.5%. So it's still considerable, but there's still I suppose a gap in terms of getting to the ideal targets, which I'll speak later. It is reassuring to see, of course, that residents in this instance, or patients, had a nearly universal coverage at over 97%. Similarly, for COVID-19 vaccine among staff and residents in long-term care for older persons, COVID-19 vaccine last year, interestingly enough, was at about a 70% uptake among staff. Residents vaccine, again, very, very high. I guess reasons for the COVID-19 vaccine uptake being maybe even higher than flu last year was, I guess, threat perception is one reason, in that we weren't out of the pandemic status at that point. It was unsure what winter would bring. The flu seasons had been somewhat nullified by the restrictions of previous years. So I guess if people were maybe opting for one or the other, they may have felt that COVID was the more worrisome one, and opted in for that on that occasion in 2022-2023 winter. The key recommendations that came from our work were that all nursing homes, and I would contend that all health and social care facilities, should have a winter preparedness plan with which all the staff should be familiar. And when I say all the staff, I don't mean just people who are in direct patient-facing care. This is about people who are business and administration, people who are domestic cleaning, catering, any other category of worker that are under the roof of your organization should be familiar with the winter preparedness plan or the key points therein. Another recommendation was around educational sessions for COVID and seasonal flu vaccine to be accessible on site to staff and residents. And again, we saw that in the main, these are run, and it's ensuring that the attendance is maximized. And that's, I suppose, within the gift of the persons in charge, who are clinical managers. Another recommendation was that all staff should be encouraged and given every opportunity to avail of COVID-19 and seasonal influenza vaccines. And I'll speak a little bit more later on about staff vaccination clinics and the way things are set up this season. Nursing homes, and again, I would contend ultimately all health and social care facilities, should ideally have a record, or even maybe a ballpark estimate of where COVID-19 and flu vaccine status is in relation to its residents, patients and staff. It isn't always the case that, you know, people aren't forced to declare their status per se, but one thing I would say where it's useful to know this in relation to staff and patients and residents is that if and when cases of an infectious disease, flu, COVID, or other do pop up, or indeed, unfortunately, when outbreaks occur, knowing how much of a protective barrier you have in that facility from vaccination, both of your patients and your staff, helps to inform the risk assessment. And certainly when it comes to us in public health departments, when we're notified, we always ask, you know, what is the vaccination level, whether we know it absolutely or we know an estimate. It's really crucial because it gives us an idea of how much of a problem might this be, how much spread might we see, how long will these outbreaks go on. Another recommendation was around education and training materials to be developed by ourselves in the public health departments and delivered to colleagues. Said nursing home colleagues here, and indeed we've run a couple of information days for directors of nursing or their deputies or persons in charge, and one took place at the end of September for CHO DNCC area facilities. And I guess by me being here today as well, I'm trying to fulfill that recommendation in discussing this topic with yourselves out in community care in CHO DNCC. And then another thing that's under development for us is around educational sessions related to winter preparedness for nursing home residents and even their relatives or next of kin, because this is all a continuum. If everybody at least has an idea of some of the core points and actions that are necessary around keeping well and being prepared, then we're in a good place overall then. So I guess I'm getting on to really the meat of this presentation, which is, why is it important for health and social care workers to be vaccinated? So I guess top of the pile is health and care workers are essentially at a higher risk of flu and COVID-19 infection. And a high vaccine uptake among health and care workers, it's key to a number of things. So one, you reduce COVID and flu infections among the group of healthcare workers. We, as a cohort of people, are generally around 10 times more likely to get the flu compared to the general population, which is not insignificant. Health and care workers were also 3 times more likely than the, say, general labour force to test positive for COVID-19. Furthermore, we want to reduce transmission to patients and also to our colleagues. Specifically in hospitalised people, patients in general, they can be from anywhere from 5 to up to 35 times more likely to acquire influenza if they get exposed to a healthcare worker or a patient who is infected. And then the problem with flu in particular is that often up to maybe 3/4 of people may not have any discernible symptoms, mild or maybe non-existent, but they can still transmit infection. And even those who do become symptomatic are infectious for a day or two even before they become unwell. So ultimately, it means healthcare workers can spread infection even when they have no symptoms, hence the reason why we want to take this so seriously. And then a final reason is that if you reduce staff sickness, it's important for winter resilience. So healthcare workers are about 7 times or therefore more likely to get severe COVID outcomes when you compare to a non-healthcare worker member of the labour force. What's the challenge currently? Current challenge is that we have a vaccination gap. The figures I'm going to present now were highlighted by the Chief Clinical Officer, Dr. Colm Henry, back in June. And these are national figures. So I'll just temper it with that these are averaged nationally and not specific to CHO DNCC. But for acute services during the last flu season in 22-23, the flu vaccine uptake was just over 40% for community and just shy of 40, or for acute it was just over 40 and it was just shy of 40 in community services. And then for COVID-19 vaccine, about 1/4 was the level of uptake in acute and just shy of 30% in community. The figures are more favourable in CHO DNCC, and I'll touch on that a little later. And that has to be commended. So for the leadership shown and the willingness of staff in CHO DNCC to come forward and receive seasonal flu vaccine and COVID boosters last year. The targets are quite ambitious within the HSC in that we're aiming for an uptake rate in flu vaccine of 75% and for 50 for COVID-19. And so I hope by this discussion to advocate and recommend and push that we try and get that level of coverage so that we can have a milder winter in terms of illness for health and care workers, and we build greater resilience into the system. Why might there be reasons for low uptake? Well, I mean, this occurs not necessarily with any specific vaccine, but it's always understandable. People may have vaccine safety fears. There may be a perception of lower risk of infection. These discussion points would have come from the after action reviews that were done nationally in relation to COVID and flu. And it mentions particularly among younger staff. I don't always buy that, but I guess once you come out of the pandemic emergency status, we're living with COVID, for example, as it were, and the threat is indeed diminished, but a lot of it is diminished because of certainly vaccination, in addition to some natural immunity from infection that people have suffered, unfortunately. But perception of risk might be that bit lower. But the thing is, these pathogens, they haven't gone away. In terms of effectiveness, these after-action reviews that were undertaken, it was interesting to read that around a third or just shy of a third of staff were not in agreement that the COVID boosters would mitigate against the risk of actually contracting the infection. And then another hesitation that comes up is around the idea of a double dose or what's called co-administration, so receiving COVID and flu vaccines in the one sitting. What's still heartening is that the intention when surveyed in these after-action reviews was that the sample of HSE staff would have indicated around 80% definitely willing to get flu vaccine this coming season, a little bit lower, about just shy of 2/3 when it comes to COVID. So what can we do? Well, always try and improve access to vaccination. So you reduce the barriers, you make it as easy as possible for people to be able to avail of them. So offering on-site, co-aligned flu and COVID vaccines to health and social care workers from early this autumn. And a lot of this is being led by flu steering committees and HSE peer vaccinators. And anecdotally, when administered by a peer in your work setting, often, I think, you have that trust with colleagues, and the availability of it as well on-site is something that really drives good uptake. Strong local governance and leadership. I mentioned in the survey we did around the residential care facility sector in North Dublin that senior clinical leaders, people in charge, directors of nursing, clinical nurse managers, these are the people that people are looking to for guidance, and you have a lot of influence in that regard. And if you lead from the front, as it were, then you can really drive good uptake through that advocacy. You hear this term about vaccine fatigue, and I guess it's understandable. It's been a very tough number of years, and there was huge willingness to and buy-in from healthcare workers and the population generally on the vaccination programs. And it can be hard to kind of go back to the well once more and say, we need to do it again because winter is coming. But that's crucial in that, as I say, these pathogens, these viruses, they haven't gone away, and they still pose a threat. And when we know we have something in our armory that can prevent and avoid ill health, we should do everything we can to try and maximize its uptake. And then strong locally led communications. So again, making good quality information available to health and social care workers. I'd push anybody who hasn't done it yet to undertake the flu and COVID vaccine healthcare worker HSE land module. I'm sure many clinical managers in different sectors of CHO DNCC have been pushing this among their staff. It's quite short, about 15 or 20 minutes, and it's useful as well as a resource in terms of getting the facts. Okay, so I'm going to just move on to kind of maybe discuss flu and COVID in a bit more detail and discuss the vaccines and try and dispel some of the myths that maybe are around it, and also kind of put out a clarion call for if you haven't got your vaccine yet to think about it and to get the facts and proceed. This is a bit of a dramatic photo, and it just shows the what comes out if you sneeze or cough and you don't smother it, or you don't have a tissue or anything in the way. And these droplets, they can spread feet or meters, and if they go on surfaces or otherwise, they can contaminate them. And we want to stop people getting to this stage in the first place, but it can be obviously inevitable. We all can be under the weather from time to time. So that's back to our first principles of our respiratory etiquette, our hand hygiene, and so on. Flu, many of this may be familiar to many of you, but if not, what is flu? It's influenza. There are 3 types of influenza viruses, A, B, and C. It's generally A and B that we see in terms of seasonal illness, and usually a predomination of type A. It infects the nose and the throat, and sometimes it can get into the lungs and cause pneumonia. It can cause quite mild illness or maybe no symptoms whatsoever, and it can cause very severe illness and lead to hospitalization and death. And that's what you're trying to avoid, especially in those who are vulnerable. I'd mentioned previously that adults are generally infectious for a day or 2 before they even get symptoms, if indeed they do get symptoms, and for up to 5 days after the symptoms appear. Oftentimes, children can be infectious for longer periods than that. As per the image in the previous slide, spread is mainly through droplets from an infected person when they cough or sneeze and it's not contained. Also, maybe they touch a contaminated surface. In terms of isolation periods, so this is more to do with like how long do you need to be, if you've confirmed influenza infection, how long do you need to be at home, or if you're a patient, how long do you need to be isolated? It's 5 days from symptom onset. And sometimes that can be extended if you're in a vulnerable group, such as being immunocompromised. So another few points on flu virus generally, and some are covered already, but it's useful in this slide as it kind of presents it as a nice continuum. The incubation period, so that's from the point of being the time at which you were infected up until you start to display symptoms, can be anywhere from 1 to 4 days. And as mentioned, 1 or 2 days before you get symptoms, you are infectious to others. When does it tend to occur? It's usually from the beginning of October to the end of April. It's classified as the flu season, so it's long, it's 6 months. How does it spread? It's droplet in the main. How long does it survive? On hard surfaces, it can survive up to 48 hours. On soft surfaces, it may well even survive from 8 to 12 hours. And on your hands, it may be only around 5 minutes. And the reason we stress the hand hygiene is that a lot of research has shown we tend to touch our face a lot, and often unbeknownst to ourselves, but especially if it's around the mouth, nose, or the eyes, the mucous membranes. That's the route of entry for flu and many other viruses. And we want to, I suppose, mitigate against that with, again, our infection prevention control measures. How serious is flu? Many people might think it's not that serious, is it? But worldwide, it causes each year somewhere between 3 to 5 million cases of severe disease and between 250,000 and 500,000 deaths. And in a bad enough flu season in Ireland, you can have between 200 and 500 people die from influenza each winter. It is indeed more severe in the elderly, those with chronic heart or lung conditions, and young children as well can be particularly susceptible. Others with chronic illnesses or pregnant women. About 80 to 90% of reported deaths do tend to occur in the elderly. But when you look at a lot of people who are in our care in different sectors of the health service, we have an aging population. A lot of people are living to older age, and when we can try and mitigate and prevent flu through our efforts with vaccination and infection control measures, we want to try and make a dent in unnecessary illness and death. And this, I suppose, just to hit home the point again around the impact, it can still affect any group, not just the elderly or those with underlying conditions. UK data would state that around 3 in 10 deaths from flu tend to be in people who were classified as previously healthy, otherwise well. I think the next 2 points are repeats from the previous, but again, the point being made here is that it can affect anyone. It disproportionately affects those who are older and who have underlying conditions, but that's where it's really incumbent on us who may be otherwise well or not in a risk group to do our utmost to ensure that we protect the more vulnerable by indeed protecting ourselves in the process. So often there's a debate around, what we think might be the scenario in relation to flu vaccine versus what the actual fact of the matter is. So we hear time and again, people may say, look, I think you can get flu from the flu vaccine, but in Ireland, the HC vaccines for adults, they only contain inactivated virus, so they can't give you the flu. Only those in at-risk groups need the flu vaccine. As mentioned, anybody can get the flu. There are recommendations about high-risk groups and the ones that are put into the national immunization guidelines, but anybody can get it, and otherwise, it's still reasonable that we recommend it for the general population also, just at the higher risk groups, there's a prioritization there in terms of mitigating that risk and doing it efficiently. Other people may say, I've never had the flu, not likely to get it. Yeah, you can get the flu without having necessarily symptoms of it. And as mentioned, the problem there is that you mightn't suffer, but you may be a vehicle for transmission to others who unfortunately will bear the brunt of it. And a lot of people might say, well, I'm fit and healthy otherwise, I don't really need it. But as mentioned in that UK slide on UK data as well, about up to a third of people who die from the flu are often classified as previously healthy, no underlying conditions. Other myths versus facts. Do you only need the flu vaccine once in your lifetime? Well, that's a myth. The flu virus, as many viruses, evolve continually, and it's always that race to work out what's maybe happening in other parts of the world. We often look to Australia during their winter to gauge how things are and to look at what strains and otherwise might be threatening us for our winter and vice versa. So the seasonal flu vaccine is called seasonal for a reason, is that it is needed each season. People may say, well, the flu vaccine doesn't work. You can still get the flu even when vaccinated. It's true that indeed people can be vaccinated and still contract a strain of flu for which the vaccine didn't cover. But for most flu seasons on average, if you are vaccinated, you can get up to 70 or 90% good protection. So it is not that it does not work, it's that it may not work in every instance. But if you're trying to put the odds in your favor, being vaccinated is a better option than not. People say, I may have a reaction to it. Flu vaccines have been given to millions of people for decades, and they are very safe. Reactions are rare reactions, or serious reactions are rare. Most people indeed may have soreness at the site of the injection, maybe a little bit of swelling or redness, may feel a bit achy or a bit under the weather themselves, maybe for a day or two, which is to be expected. But outside of that, true influenza, if you suffer it and get a symptomatic form of it, is going to be a lot worse. Flu isn't serious, it's just like a bad cold. Well, I guess I've already mentioned a lot of the salient points that, flu can kill people, the complications can be life-threatening, and it causes hospitalization and death in Ireland every year. So it's something we want to mitigate against any time it's threatening us. I'll touch on COVID now, and I suppose we've spent a lot of the last few years focused on COVID, so many people may know the salient details on this. Just some headline figures in terms of cases. So between January 2020 and up to present, almost there's been about 1.7 million confirmed cases and about 9,200 deaths in Ireland. In terms of vaccination doses, as of around midsummer 2023. About 12.3 million doses administered. COVID, how does it spread? So again, it can spread in droplet, and it can indeed at times be aerosolized. And again, like that image of somebody with an uncovered sneeze or cough, that is your route for transmission in the main. And these particles scatter when someone coughs, sneezes, or even talks. Our current isolation guidance, so if you were a confirmed case, it is for 5 days from the onset of symptoms. And generally, you can exit from that if you've substantially resolved symptoms. It can be extended if people remain symptomatic for longer, or perhaps if they are immune compromised or otherwise. And I've put the link here in the slide to the current Health Protection Surveillance Centre HPSC guidance. This is a really interesting point of information that was undertaken by colleagues at the Health Protection Surveillance Centre and is, I think, due for formal publication very soon. They undertook a study looking at, well, what's been the impact of the COVID-19 vaccination program to date. They looked at the point from December 21 to March 23, and the headline figures here are in bold, and these are obviously modelled in their estimates, because I guess the one thing in public health practice that we can't do is we can't literally measure the disease that didn't happen, but estimates can be made. And the figures are quite sobering, but also quite heartening, in that 36% of expected symptomatic COVID presentations to primary care or community testing centres were averted by people being vaccinated. Over half of expected emergency department presentations, 81% of expected hospitalizations, almost 90% of ICU admissions, and again, almost 90% of expected deaths, which is is quite staggering. There of course may be certain limitations and caveats in that study, but as headline figures, that is you know, it is brilliant reading, and hits home the point around, you know, what, when each one of us chooses to be vaccinated against COVID-19, what we are contributing to in terms of population health and preventing ill health. In terms of flu and COVID booster vaccines, this year, the seasonal flu vaccine contains 4 strains. That's generally the case. There's two type A and 2 type B strains, the ones that are most likely to be circulating. This year, they're formally co-aligned, so they can be given at the same time, and it's safe to get them in both in one sitting. We give vaccines, several, 2, 3, maybe even 4, to infants in their primary childhood schedule. Same for kids in their booster in primary school. Similarly, for people when they maybe travel abroad and need ones for other tropical infections, people may take multiple injections at the same time. So it's not anything new to co-administer. As mentioned, the target uptake rate is ambitious. It's 75% for flu and 50% for COVID. The national uptake last year, on average, was among healthcare workers was 43.6. These, as I say, I believe in CHOD-NCC, it was around the 60% mark. So again, you know, colleagues are to be commended for the efforts involved in reaching that level of coverage. Who should get vaccinated? I've used the title health and social care worker in this presentation. It's recommended for all those who work in health and social care settings. So that's medical, nursing, paramedical, allied health staff, students, dental personnel, portering staff, cleaning staff, general support staff, ambulance personnel, staff in disability and social care services, especially if it's residential setting, administrative staff, carers, home helps, GP practice staff, agency staff that are in any of the above categories, and any staff who are pregnant. Pregnant women are more likely to get complications of flu because of changes to their cardio and respiratory function during pregnancy. These pieces of information are courtesy of colleagues in CHOD-NCC flu leads. There were some successes to be celebrated from last year's campaign, in that the delivery and availability of vaccine was timely, it was excellent. Colleagues received very good support from our colleagues in the National Immunisation Office in Public Health. 61% of staff who received in the CHO received their flu vaccine. That was nearly 2,700 people, and that was an increase upon the previous season. In long-term residential care, older persons, almost 70%. It was a decrease versus the previous season, but nonetheless a very high level achieved in and of itself. And then of the 61% CHOD-NCC health and social care staff who received their flu vaccine, 40% of those went via the COVID vaccination centre. So the collaborations with the community vaccination centres at Swords and Croke Park worked very well. So on-site co-aligned vaccinations by peer vaccinators for this season. So that's what's being offered in long-term care and through primary care clinics, administered by nursing and midwife peer vaccinators. And I think I mentioned earlier that, you know, it's been shown anecdotally that staff are generally more likely to get it if it's administered by a peer or a colleague. The COVAX system, which was used and brought on stream for COVID-19 vaccines, is being used, and SwiftQ to book appointments. There's incentives, and I'll touch on that just before the end of the talk, around annual leave days, the Get a Vaccine, Give a Vaccine campaign, and also vouchers and hampers and so on, and the training and clinical governance is supported. What is co-administration? I touched on this. It's meaning to administer more than one vaccine in a single visit, and it's common and it's a safe medical practice. As I mentioned, it's done for children in infancy, in schools, and also people traveling, etc. It's ideally geared to provide convenience for the person being vaccinated and also to increase uptake. It also has economies of scale and it's more efficient, so it saves time and money. And you also then will achieve your immune response that bit quicker as well. Flu, you know, you generally need up to 2 weeks before you'll get the immune response. So you might say, oh, I'll take my COVID today, but I'll take the flu one next week or the week after. And ultimately, it's a month's time then by the time you're maybe immunized such that you have protection. Boosters, and I suppose specifically around COVID-19, well, why do we need boosters? Well, booster doses serve to protect the individual, their families, the communities in which they live and work, and you create a wall of immunity. So immunity doesn't last forever from vaccination necessarily or from natural infection. And so if it wanes, you want that top up to your immunity. And that's the reason to boost, particularly ahead of the winter season. These are just some of the communication materials you may have seen around. And I suppose it's to my original points around, if you work in healthcare environments, you're at increased risk of being exposed to flu and COVID, and ultimately suffering illness from it, and potentially spreading it not only to residents or patients, but also to colleagues, and also even at home to friends or family. And so co-administration of COVID and flu is the real push for this year. I again implore people to undertake the HSE Land training. It's short, it's informative, it's very useful. So to sign in on HSE Land and look for the, in this case, I've shown a screenshot of the flu vaccine 23-24 season login portal. There are also really good resources in the National Immunisation Office. I've put a clip here of a presentation that's done around talking to health and social care workers around COVID vaccines. This may be particularly useful for those of you who are in a clinical management position. People can be hesitant, and it's important to understand reasons why they might be hesitant, but otherwise willing if due care and attention and time is given to explaining and understanding and giving the facts in relation to the disease and also the vaccine and why it helps. We need to practice what we preach, of course, and these are screenshots from my own colleagues here in the Department of Public Health getting their COVID and flu vaccines just last week and this week. The colleague giving the vaccines is our health protection nurse, Sarah Barrett, who trained to be a peer vaccinator. And I think the footfall through the clinic has been very good in these first couple of weeks, and we want to see that maintained. And it's a great initiative, and it really bears fruit. So I think, as maybe a set of parting words, I'd say don't delay, get your vaccines today. On screen, I think the QR code can be scanned and utilized even through the slide deck here or in the recording. There's a whole schedule into November already published for sites in primary care and other settings in CHOD and CC. And I suppose finally, just a real push to say, I'd recommend strongly that you do get both, that you get them at the same time, that you get immunized as quickly as possible. You want to keep yourself well, keep your patients well, keep your family well, and then we build resilience and otherwise for the health system for the season ahead. So Gurmila Magav, and thank you very much.
Thank you, Dr. Paul, for an extremely informative session. It was really interesting to learn the myths versus the facts, and it was a little scary to listen to the numbers, the 200 to 500 deaths every season in the flu deaths in Ireland every season. But again, that emphasizes the importance of getting the vaccine this winter. And thank you for sharing the resources with us. And if you have any questions for Dr. Paul and you haven't popped them into the Q&A toolbar, please do it now and we'll try and get to it now. Is it okay if I go into the questions, Dr. Paul?
Yeah, absolutely. Please do.
The first one is there a standard SOP, one that's adaptable for local areas and in case of a flu outbreak?
Yeah, very good question. It's indeed on the Health Protection Surveillance Centre, the hpsc.ie website. There are outbreak checklists that can be adaptable to not just a specific pathogen like flu or COVID, but they outline the, I suppose, pre-outbreak. So in peacetime, before anything is occurring, in terms of a preparedness plan, then what to do in terms of ensuring, how do you ensure you have appropriate isolation, and also how to step down those things afterwards. So I can provide later on, if necessary, if I haven't already, through the links that are in the presentation, ones to you and colleagues in Health Wellbeing, CHOD, NCC for dissemination. But the Health Protection Surveillance Centre has templates, or they're contained within guidance documents that can be used around outbreak management. They may need to be, of course, tailored to a certain extent depending on the setting, but the core tenets of it still ring true in terms of the infection prevention control measures, risk assessment in terms of then do you need personal protective equipment, for example, and also things around testing, isolation, and what have you. But there are indeed templates with the HPSC.
Thank you. And what do you think are the reasons behind low uptake of the flu vaccine? Can you share any research on relation to vaccine hesitancy? I think you have mentioned some of it already.
Yeah, I think there's a few links in the slide deck I've put, and also I think some are in the notes section, and they can be shared as well with colleagues on the call. But as for a reason for, say, lower uptake of flu vaccine, I think it's the classic term of multifactorial, in that we haven't had to deal with flu actually kind of in much of a great sense for a few years. The seasons, as I say, were kind of nullified because when you didn't have people coming together because of lockdowns and otherwise, you didn't have opportunities necessarily for it to spread to the same effect. Perhaps indeed then when the focus was on, and rightly so, I guess, at the time, on COVID-19 vaccination and immunity, it may have maybe displaced the kind of focus for people. And we're only bringing ourselves back around now in terms of, flu is actually occurring again because society has reverted to normal. COVID hasn't gone away. So now, I have a number of things that are on my plate in terms of I need to protect myself against. So that relates back to that vaccine fatigue, as the term has been mentioned. I think some of the reasons I would have outlined in maybe the myths versus fact section, where people can be, I suppose, thinking, well, it's not particularly maybe effective, or it doesn't work. And it's not, as I say, it's not that it doesn't work, but it's a piece of work each year to try and match it as best as possible to circulating strains. So it's not a silver bullet in that it'll be 100% effective, but maybe in some people's mind, it's like, well, if it isn't that strong, maybe I won't bother getting it at all. But we see that the converse of that is, by being unprotected against it, you potentially run the risk of getting, a severe illness or worse, particularly if you're in a risk group.
And the next question, thank you. And next question is there any further training that you recommend for healthcare staff in relation to vaccines that we should be doing?
Further training in relation to vaccines, I'm just, in case I'm misinterpreting the question, I don't know whether that's about people who want to become vaccinators, or if it's about information that they need to disseminate to staff. So I don't know whether the person who's made the question.
I think it's about I think it's about the information, you would.
Yeah.
Like
so I think a place that is, I would always say that the good place to start all round is to go to the National Immunisation Office's website at immunisation.ie. It's broken down into sectors for, the general public, but also for healthcare professionals. And it's really useful to go in there, and it's stratified according to different viruses or bacteria or different pathogens. And many sections have FAQs, and they're very much focused for the healthcare setting, and also to arm people with, if someone comes to me as the healthcare professional with these kind of questions, where do I direct them to, or how can I better inform myself? And one thing I omitted to say, I think, in the presentation is that health and social care workers are, we are a trusted voice still, despite what people might think otherwise. We're generally, quite highly ranked in terms of trustworthiness. So people will come to someone who works in a healthcare setting and say, what do you think I should do about this? Or, what information is there? So, arming ourselves with that information, particularly when it comes to vaccines, I would say that the National Immunisation Office is probably one of the key repositories for information, and it's in various different forms in terms of video, information leaflets, FAQs, and so forth. So that's where I would kind of point people in the first instance.
Thank you. And is it safe to get the pneumococcal vaccine along with the flu and the COVID together?
Yeah, I didn't touch on, I suppose, pneumococcal. And in general, yes, there are specific, I suppose, guidance around pneumococcal in terms of people who may be at risk for it. But there's only one exception usually, and it's usually for preschool age children where there does need to be an interval. So if a preschool age kid gets, for children, it's called the LAIV or live attenuated influenza vaccine. It's a nasal spray, so no needles, which is great. If they receive that, plus or minus COVID vaccine, usually you need to wait a couple of weeks just in terms of immune response. But for adults, yes, yeah, it can be administered co-aligned or co-administered.
Just because you have mentioned the children there, are the children also getting the flu and the COVID-19 this year? Or is there any age group?
Well, I guess COVID-19 vaccines are recommended for anyone in the population aged from say age 6 months and up. In terms of flu vaccine, it is recommended from age 2 and up. And specifically if you're aged 2 to 12, so preschool to the end of primary school, the LAIV, the nasal flu vaccine, is recommended. Colleagues in the CHO areas, vaccination teams there, it's a big undertaking. They are doing it's not so much a pilot per se, but they're bringing it into schools for the senior infant classes in the first instance, and also to special educational needs schools for all attendees there. You can imagine with the number of schools in the Greater Dublin area and the number of pupils, it's not a small undertaking. But it's to ensure, if you're going to expand that, in future years, how efficiently you can do it in a defined cohort. But it is nonetheless recommended for the other kids in that wider age group. And to my point around flu and infectiousness and spreadability, as it were, preschool age kids in particular are, they are champions at spreading infectious diseases, particularly respiratory viral infections. So getting the LAIV, there's no needles. Indeed, because it's live attenuated, they may be more likely to experience, irritability or some even mild fever, so high temperature afterwards. That is to be expected. But again, we see a lot, unfortunately, of kids under the age of 4 get ill and hospitalized each season when there's a particularly bad flu season. So we want to mitigate against that. So I'd also advocate people on the call here that if you do have kids that fall into the requisite category, that to put them forward or get them vaccinated, because again, they can obviously pick it up in the community or through childcare or school and bring it into a family setting. And then if you're unvaccinated or lesser protected, you may bring it into a work setting and so on.
Thank you, Dr. Paul, again for your lovely presentation, and thank you everyone who joined us today. This webinar is recorded and will be available for playback on our YouTube channel, the Health and Wellbeing YouTube channel. And our next lunchtime webinar is on 17th, that's next Tuesday. This is on prevention and early diagnosis of cancer by Dr. Una Kennedy. And we also have the face-to-face Culture and Diversity Day event on the 18th of October, Wednesday, in the lecture hall in St. Mary's Hospital from 9 to 1. Please scan the QR code which would appear on the screen shortly to register for any of our future webinars. Before we wrap up today's session, we would really appreciate if you could scan the QR code which would again appear on the screen shortly and complete the survey. And by doing so, your name will be entered into a draw to win a €25 one-for-all voucher. So with that, we are wrapping up today's webinar. Stay safe this winter by getting your flu vaccine and your COVID-19 vaccine, and have a lovely weekend. Thank you.